Welcome once again to our online lecture series on the aerodigestive organs of the head and neck region. In this particular lecture, we are going to focus on the third aerodigestive organ, which is the pharynx. Just to bring you to perspective, is that we have chosen to divide the lectures on the aerodigestive organs of the head and neck region into multiple parts for the sake of delivery. So the first one was on the nose and nasal airway. The second one was on the mouth and oral structures. This is the third one. We are focusing on the pharynx. We are yet to look at the larynx, the cervical trachea, and the cervical esophagus. So let's look at the pharynx. The pharynx is also known as the throat. It's a muscular membranous tube that extends from here, the base of the skull, to around here, the upper part of the esophagus. So it's a very long tube. This is the skull base related to the sphenoid bone, as well as the clevus or the basilooccipital bone there. And down here, this is the cricoid cartilage, which marks the end of the pharynx and the beginning of the esophagus. So as I've mentioned already, superiorly, the pharynx is limited by the sphenoid bone as well as the basilar part of the occipital bone. You can combine the basilar part of occipital bone together with the posterior part of the sphenoid and call that the clevus. So limited superiorly by the clevus and inferiorly, the pharynx is continuous with the esophagus at the level of the cricoid cartilage. The anterior wall of the pharynx is largely deficient because it's related to spaces. Like this region is related to the nasal cavity. This region is related to the oral cavity. And this region is related to the laryngeal inlet. So most of the anterior wall of the pharynx is actually deficient. It is not there. Based on those three spaces, nasal cavity, oral cavity, and laryngeal inlet, the pharynx is divided into three zones anatomically. Those three zones are these ones. So we have here the nasopharynx, and here the oropharynx, and here the laryngeal pharynx. So with that, let's look at our learning outcome. This is what we want to learn in this lecture. First, we are going to look at the parts of the pharynx and in particular, look at the morphological features of each part of the pharynx. After that, we are going to look at the histological structure of the pharyngeal mucosa, and we'll also look at the histology of the tonsillar tissues around the pharynx. We'll then mention something about the musculature of the pharynx. They are in two groups, circular and longitudinal group. And we'll also talk about the blood vessels and the nerves that supply the pharynx. Starting with the first agenda, the parts of the pharynx, we've already highlighted that the pharynx has three parts, and these three parts are based on the spaces which are related to the pharynx anteriorly. So the nasopharynx is related to the nasal cavity at the level of the choana. That's the nasopharynx still. That's where we expect the choana. The oropharynx is related to the oral cavity, this region, so that what we can see here is that it's extending from somewhere there to somewhere there. The junction between the oropharynx and the oral cavity is what we call the oropharyngeal isthmus, which is marked by structure we call the anterior pillars of fauces, located somewhere here, formed by a fold, the impression of a muscle that comes from the palate to the tongue, therefore called the palatoglossus muscle on either side of the oral cavity stroke pharynx. The laryngopharynx, on the other hand, extends from somewhere there, going down, and it's related to the laryngeal inlet. Well, some part of the laryngopharynx still continue down, not necessarily related to the laryngeal inlet. Let's begin with the nasopharynx. So the nasopharynx is a region of the pharynx that lies above the soft palate and behind the choana. So this is the choana, the posterior nasal aperture. This is the soft palate. So this is the region of the nasopharynx. Generally, the nasopharynx has a bony wall. On the roof, we have the sphenoid, we have the basilar. On the sides, have bones behind as well. And because of this bony wall, it is difficult for the nasopharynx to be constricted because of muscle contractions, unlike what happens in the oropharynx and laryngopharynx, where the lumen of the pharynx can be obliterated depending on the tone of the musculature in these regions. And so you understand, therefore, that, like, for example, people who snore because of muscle relaxation of the pharynx, that it will largely as a result of the relaxation that has affected either the oropharynx or the laryngopharynx, but not the nasopharynx. That does not mean that nasopharynx cannot be obliterated. It can still be obliterated, except the obliteration is not necessarily because of muscular contractions. Could be because of something else, like perhaps the pharyngeal tonsils that you see there. We'll say something about it shortly. So yes, we're already there, that the roof and posterior wall of the nasopharynx houses the pharyngeal tonsil. Pharyngeal tonsil is basically an aggregation of tonsillar tissue within the mucosa of the nasopharynx. And I'll be showing you shortly how tonsillar tissue looks like histologically. But in a nutshell, remember, it's a lymphoid tissue. So these ones, if they become inflamed, they can actually enlarge to a way that they narrow the nasopharyngeal airway. That can still be a cause of snoring. When they are enlarged, we commonly call them adenoids. Now, there are some features that we note on the lateral wall of the nasopharynx. One of them is the opening of the eustachian tube. The eustachian tube connects the nasopharynx to the middle ear. This is the mechanism that the ear uses to balance pressure between the middle ear and the outer ear. And it is important to balance pressure between the middle ear and the outer ear so that we have normal tension of the eardrum, or what we call the tympanic membrane. So the eustachian tube, which is also known as the pharyngotympanic tube, connects the nasopharynx to the middle ear, which is called the tympanic cavity. The wall of the eustachian tube is partly bony, partly cartilaginous, just to maintain its patency. The other thing that we note on the lateral wall of the nasopharynx is a tubal elevation. So this elevation there, we can call the tubal elevation or the tubal ridge. It marks the medial end of the skeleton and mucous membrane covering the skeleton of the eustachian tube. On that tubal elevation, we usually have, again, another aggregation of lymphoid tissue, which we call the tubal tonsils. Note that the tubal tonsils can be considered to be bilateral because you have right and left. Unlike pharyngeal tonsil, that it's just one midline structure. This image still shows us the part labeled 17, which is the tubal elevation. This 16 would be the opening of the eustachian tube. That 17 would be the tubal elevation. And on that tubal elevation, we have the tubal tonsils. Take note that these are the ones at the conchae of the nose, so the inferior turbinate, the middle turbinate, and the superior turbinate there. This is the sphenoidal air sinus. This is part of the cleavers. This other one is the hard palate and a soft palate there. Another structure we see on this wall is the salpingeal pharyngeal fold. The salpingeal pharyngeal fold is this fold here that is arising from the tubal elevation going downwards to the pharynx. So this salpingeal pharyngeal fold is in the impression left or formed by the salpingopharyngeus muscle, one of the longitudinal muscles of the pharynx arising from the tubal ridge going downwards to the pharynx. We also have the salpingopalatine fold, which is this one labeled 15. It's a small fold extending from the anterior part of the tubal ridge to the palate. It's usually a smaller one compared to the salpingopharyngeal fold. Note that the salpingopharyngeal fold is a posterior fold, and the salpingopalatine fold is an anterior fold in relation to the opening of the eustachian tube. Then we have the pharyngeal recess, or also known as the fossa of Rosenmuller. This is the pharyngeal recess of the fossa of Rosenmuller, extending much higher, a bit obliterated in this one, but in this image you can see it better. So the part pointed there is the pharyngeal recess of the fossa of Rosenmuller. Take note that again, this is the tubal ridge with salpingopharyngeal fold, opening of the eustachian tube. This salpingopalatine fold is that one. Great, so that's nasopharynx. What are some of the communications of the nasopharynx? The nasopharynx communicates with the nasal cavity via the choana. So this is the choana or the posterior nasal aperture. So this nasopharynx and that nasal cavity. Nasopharynx also communicates with the oropharynx through this region here, which we call the pharyngeal isthmus. So the pharyngeal isthmus is this region, space formed by the gap between the soft palate and the posterior wall of the pharynx there. So this narrow gap there is what we call the pharyngeal isthmus. Laterally, the nasopharynx communicate with the tympanic cavity. the eustachian tube, as we have already mentioned. Perhaps I want to think about the clinical importance of these communications. What can we highlight as something clinical about each of these three communications? Think about them. Now let's talk about oropharynx. The oropharynx extends from the level of the soft palate there to the upper border of the epiglottis there. So this region is what we call the oropharynx. The lateral wall of the oropharynx consists of the palatoglossal arc, which is also known as the palatoglossal fold. So again, this is another fold formed from the presence of a muscle arising from the palate to the pharynx. Again, another longitudinal muscle from the palate to the pharynx. So we call that the palatoglossal. So we call this the palatopharyngeal fold. And this anterior one is the one we're calling the palatoglossal fold. So let me clarify that again. From the palate, we have some muscles that go down, one to the tongue and another one to the pharynx. The one going to the tongue is called the palatoglossal muscle. The fold it leaves is called the palatoglossal fold. Then we have another muscle going to the pharynx, another longitudinal muscle to the pharynx. Remember, the first one was the salpingopharyngeal muscle. So this second one is the palatopharyngeal muscle we're mentioning. And so the fold left by that muscle is called the palatopharyngeal fold. These two folds are related to the palatine tonsil there. And with respect to the location of the palatine tonsil, we see that these folds form some pillars. We call these pillars the pillars of Pharynx. And so the palatoglossal fold is the anterior pillar of Pharynx. And the palatopharyngeal fold is the posterior pillar of Pharynx. The palatine tonsil is between the two, lying within that depression, which we call the tonsillar bed. So remember, the palatoglossal fold, the anterior pillar of Pharynx, is the one that anatomically separates the oral cavity proper from the oropharynx. And so we can consider the posterior tongue to be in the pharynx and the anterior tongue to be in the oral cavity proper. Take note again that that gap formed by the anterior pillars of Pharynx is what we call the oropharyngeal isthmus. And so if you are to look at communications of the oropharynx, we can say it communicates with the oral cavity through the oropharyngeal isthmus. It also communicates the nasopharynx through the pharyngeal isthmus, this one. And of course, communicates again with the laryngopharynx down here through that gap. This image shows us the image of someone's oropharynx with the uvula a bit prominent there and palatine tonsils prominent. I put this so that we can see the anterior pillar of Pharynx, which is this one, and somewhere around there, constituting the boundary of the oropharyngeal isthmus. So beyond there, that's palatine tonsil, and this is the posterior pillar of Pharynx. That's the posterior pharyngeal wall at the level of the oropharynx. This is the tongue. The third part of the pharynx is the laryngopharynx, situated behind the entire length of the larynx, ideally from the upper border of the epiglottis to the level of the cricoid cartilage. We also call it the hypopharynx clinically. Its superior part is related to the laryngeal inlet, which is the part where air passes, like so air comes like this through the nose to the nasopharynx, then oropharynx, then enter the laryngopharynx, then enters here to the laryngeal inlet. We take note that some part of the laryngopharynx are actually related to the posterior part of the larynx, so it's not necessarily deficient as the predominant story. This shows us a dissection displaying the laryngeal inlet and perhaps the anterior wall of the laryngopharynx, as you can see from this view. So with this being the tip of the epiglottis, the depression between the epiglottis and the posterior tongue is called the vallecula. That would be part of the oropharynx, ideally. We have the epiglottic cartilage here, and behind here we have what we call the arytenoid cartilages. And so we have this fold here, which we call the aryepiglottic fold, which form the boundary of the laryngeal inlet. So the boundary of laryngeal inlet being formed by epiglottis anteriorly, the arytenoid cartilages posteriorly, and the aryepiglottic folds on either side. Lateral to the aryepiglottic folds are these depressions here, which are part of now the laryngopharynx. We call them the piriform fossa. So lying on either side of the laryngeal inlet and being part of the laryngeal pharynx. This lower part of the laryngopharynx would be related to the posterior aspect of the larynx, as we can see. So that summarizes for us the morphology of the different parts of the pharynx. Now we can look at the structure of the pharyngeal mucosa, as well as the tonsillar tissues of the pharynx. So the pharyngeal mucosa is the mucosa that lines the pharynx, basically. The mucosa that lines the pharynx is continuous with different parts of mucosa. For example, it's continuous with the mucosa of the nose. It's continuous with the mucosa of the mouth. It's also continuous with the mucosa of the larynx. It's continuous with the lining of mucosa of the auditory tube and the like. So it's continuous with those spaces. And generally speaking, this mucosa will be similar to the mucosa of the nasal cavity, being respiratory epithelium, in particular at the level of the nasopharynx. So when you look at the mucosa, at the pharyngeal mucosa at the level of the nasopharynx, it will be similar to the respiratory mucosa that we noted in our previous class on the nasal cavity. The epithelium of the oropharynx and the epithelium of the laryngopharynx are adapted to withstand abrasion caused by food as we swallow. And for that reason, those regions will be lined by stratified squamous, non-keratinizing epithelium, just like what we see in the esophagus. So it has stratified squamous epithelium. to withstand friction or abrasion caused by food. So this shows us the stratified squamous non-keratinizing epithelium, which we note in the pharyngeal wall, mainly in the oropharynx and in the laryngopharynx. Deep to the epithelium, we have aggregations of lymphoid tissue, and there are particular aggregations that we then call the tonsils. And you should be aware about the Walde's ring. The Walde's ring are basically a ring of tonsillar tissue around the pharynx. So we have the pharyngeal tonsils, we have the tubotonsils, we have the palatine tonsils, and lastly, we have the linguotonsils. It's an interrupted ring of tonsillar tissue around the pharynx. Generally, these aggregations will be within the lamina propria of the mucosa. On its surface, what we see on this epithelium is that the epithelium display a lot of convolution with multiple crypts. These crypts are important to increase the surface area over which perhaps an organism can possibly interact with the tonsillar tissue. So these tonsillar tissue are basically present in multiple sites, as I've already mentioned, at the roof of the nasopharynx, on either lateral wall of the nasopharynx as tubotonsils, on either side of the oropharynx as palatine tonsils, and on the dorsum of the tongue as linguotonsils. Each tonsillar tissue consists of multiple lymphoid follicles, as you can see here, lying beneath the lamina propria of the pharyngeal mucosa. Pharyngeal mucosa being highly folded into multiple crypts to increase the surface area of interaction between the surface and the tonsillar tissue. So these are their predicted locations: pharyngeal tonsils there, tubotonsils, palatine tonsils, and linguotonsils. Remember, collectively, we call them the Walde's ring. All right, now we talk about the muscles of the pharynx. There are two types of pharyngeal musculature. We do have the circular muscles, which we call the constrictor musculature of the pharynx. And we do have the longitudinal muscles, which we call the elevator muscles of the pharynx. The pharyngeal constrictors run in a circular fashion, as I've already mentioned. So they arise from various anterior structures and insert posteriorly through a midline raphe that we call the pharyngeal raphe. There are three muscles: the superior pharyngeal constrictor, the middle pharyngeal constrictor, and the inferior pharyngeal constrictor. The inferior pharyngeal constrictor is commonly viewed to have two parts: the part arising from the thyroid cartilage being called the thyropharyngeus part, and the part arising from the cricoid cartilage being called the cricopharyngeus part. But the whole thing is the inferior constrictor. This is the middle constrictor, that's the superior constrictor. The longitudinal muscles, on the other hand, are vertical muscles. They arise from some superior structures and insert inferiorly. So we have one arising from the styloid process. This is the styloid process. It's part of the temporal bone. So the muscle with it is known as the stylopharyngeus muscle. We had also mentioned about the palatopharyngeus muscle, and we'd mentioned about the tubo or the salpingopharyngeus muscle. So those three, again, are the longitudinal muscles of the pharynx. Something unique about the arrangement of the longitudinal and the circular muscles of the pharynx is that while in the rest of the GIT, the muscles of the pharynx, the muscles of the GIT, or rather, are arranged in such a way that you have inner circular layer and outer longitudinal layer of muscles. In the pharynx, there are two exceptions. The first exception is that for the pharyngeal musculature, the longitudinal muscles are inside. The circular muscles are outside. So even if you're seeing this from outside, it actually pierces to go in, and so a good length of it will be running on the inside. The second distinction between pharyngeal musculature compared to the rest of the muscles of the GIT is that while the rest of the muscles of the GIT are predominantly smooth muscles, the pharyngeal musculature are skeletal musculature and not smooth muscle. But there's a rider to this. We know that smooth muscles are involuntary, while cardiac muscles are also involuntary, and that skeletal muscles are voluntary. That, however, is not the case for the pharyngeal skeletal musculature. The pharyngeal skeletal musculature, although they are skeletal muscles, they are also involuntary. So this is a unique type of skeletal muscles which basically are involuntary. And that's why the pharyngeal phase of swallowing is an involuntary phase, in as much as the muscles involved there are skeletal musculature. A point to note about the pharyngeal muscles is that all the muscles of the pharynx are innervated by the pharyngeal plexus, except two of them. One is this one here, the stylopharyngeus muscle, which is innervated by the glossopharyngeal nerve, this 9th cranial nerve. And we also have the cricopharyngeus part of the inferior constrictor being innervated by the recurrent laryngeal nerve, a branch of the vagus nerve. So other than those two, the rest of the musculature are innervated by the pharyngeal plexus. Now, pharyngeal plexus is a plexus of nerves contributed actually by the cranial nerve number 9, glossopharyngeal, cranial nerve number 10, vagus, and cranial nerve number 11, the cranial accessory nerve. Even if you look at it that way, we note that most of this pharyngeal musculature their motor innervation is actually being derived from the cranial accessory component of the pharyngeal plexus. So those other muscles, the superior, middle, and upper part of inferior constrictor, the longitudinal muscles other than the stylopharyngeus, these muscles are innervated by the cranial nerve number 11 through the pharyngeal plexus. And then stylopharyngeus is innervated by glossopharyngeal, and the cricopharyngeus part of the inferior constrictor innervated by the recurrent laryngeal nerve. Take note that the longitudinal muscles will raise the pharynx up, so they are elevators. The constrictor muscles will narrow the cavity of the pharynx when they contract, so they are constrictors. This image shows you the longitudinal muscles. So this is the stylopharyngeus. You can see even if it's coming from outside, it enters. And then we have here the salpingopharyngeus and the palatopharyngeus. And this is inside of the pharynx, from the nasopharyngeal region going down to the oropharyngeal region. Now let's do the last part, the neurovascular supply of the pharynx. Starting with the arterial blood supply, the arterial blood supply to the pharynx come from branches of the external carotid artery, and in particular, the following. We have the ascending pharyngeal artery, which is a branch of the external carotid, perhaps the first medial branch of the external carotid artery. We have the ascending palatine and tonsillar branches of the facial artery, the facial artery being one of the anterior branches of the external carotid artery. We have branches of maxillary artery. The branches we're talking about here, the greater palatine and the pharyngeal branches of the maxillary artery. Again, the maxillary artery is a terminal branch of the external carotid artery. We have the dorsolingual branches of the lingual artery. And again, the lingual artery itself is a branch of the external carotid. It's an anterior branch of the external carotid artery. About the nerves, the motor as well as the sensory branches, or rather the motor and the sensory nerves to the pharynx, are basically derived from the pharyngeal plexus, as I've already mentioned. And already told you that the pharyngeal plexus is formed by the glossopharyngeal nerve. This is the 9th cranial nerve. Vagus nerve, the 10th cranial nerve. And we also have the 11th cranial nerve, which is the cranial accessory nerve. The reason why it's not added to this list is because we do not quite see the 11th cranial nerve extracranially, because it joins the territory of vagus. Perhaps that's why it's even called the accessory nerve, because it accesses the territory of the vagus nerve. So what we see going to the plexus is basically branches from vagus and branches from glossopharyngeal. But if you are to trace the branches with the fibers within vagus nerve to their origin, we'll trace some of them to the original vagus nerve from the brainstem, and other fibers from the original accessory nerve from the brainstem. Now, we also have contributions to this plexus from the superior cervical sympathetic ganglion, giving us postganglionic sympathetic fibers for sympathetic functions around the pharynx. Great. So this summarizes for us the innervation of the pharynx. Remember, glossopharyngeal will innervate the stylopharyngeus muscle, motor in function, but it also innervates the mucosa of the pharynx, sensory in function. Vagus nerve, the actual vagus part, will have sensory function to the mucosa of the pharynx. Its recurrent laryngeal branch will supply the inferior pharyngeal constrictor, the cricopharyngeus part. Then vagus branches, which are originally from the cranial accessory, will be innervating most of the muscles of the pharynx, motor innervation. So that summarizes this. I'd want you to check something on the gag reflex as with regard to innervation of the pharynx. So find out the afferent roots, find out the efferent root, and find out the clinical relevance of this reflex. Thank you very much. So we'll stop there in this lecture. Our next lecture on this digestive organs of the head and neck region will now be on the anatomy of the larynx. Thank you.